Hi, I'm Anna, and this is a recording of the cardiovascular and peripheral vascular checkoff. I have already come in the room, washed my hands, and introduced myself to my patient Rachel here, so we are going to begin the exam. To start off with, we are always assessing the general inspection of the patient, seeing if they're in any visible distress, discomfort, and the patient appears to be resting comfortably. No abnormalities are noted. We will then be moving on to inspecting the chest wall for any visible heaves or thrills. We will kind of pull down the patient's shirt here for privacy purposes and just inspect the chest wall. We do not, again, cannot visualize any of those things. For the next part of the exam, we will be palpating for those. Again, lifts, heaves, thrills. We're going to be palpating in the same area that we are going to be listening to the heart sounds, and so that's going to be sorry, my hands are cold, the aortic area, the pulmonic area, Erb's point, the tricuspid area, and the mitral area. And this is also the point of maximum impulse, and so should be the fourth or fifth intercostal space, mid-clavicular line, and we do palpate that here. A shift in that may be a sign of an enlarged heart or other abnormalities that would need further testing. For the next part of the exam, we're going to listen in those same places. We are now listening for any murmurs or abnormal or extra heart sounds. Again, the aortic area, pulmonic area, Erb's point, tricuspid area, and the mitral area. We are going to do the same thing with the bell of the stethoscope, assessing for any bruits. So there were no murmurs, bruits, or abnormal heart sounds noted for this patient. For the next part of the exam, we will move on to the peripheral vascular part of the exam. So to start, we are going to inspect the external jugular vein. For this, Rachel, if I could have you just look to your left. And so what we're assessing for is just a visible impulse, but not one that is extremely full or bounding. In a patient where you may be concerned for fluid overload or heart failure, you would measure the JVD. We're not going to do that for this exam, but in a patient that was hypovolemic or something, or low volume hypotensive, you'd have a low JVD, and then for hypervolemic or heart failure, they may have an increased JVD. For the next part of the exam, we are going to palpate the peripheral pulses, and so we're going to start. I'm going to come over my patient here. We are going to palpate the temporal pulses, and then the carotid. Again, we do this one at a time. And then we move to the brachial. And the radial. The posterior tibial. And the dorsalis pedis. While we are here, we can assess for lower extremity and pedal edema. That is not noted in this patient. Again, would be possibly a finding in a patient with heart failure or fluid overload. For the next part of the peripheral vascular exam, we're going to be auscultating for bruits in those same areas. Do the temporal. also going to auscultate for bruits in the abdominal arteries. So we'll start with the aorta. And then we move to the renal. And the iliac. And finally the femoral. We're also going to palpate the femoral as well. And then we are going to move to testing the radial artery and ulnar arteries for patency with the Allen test. And so for that, I'm going to palpate both the pulses here. And then Rachel, if you go ahead and make a fist with your hand for me. And then open your hand. And I'm going to release the radial. We see the blood flow return. I'm going to let our wrist relax. And then we'll do the same thing again. And go ahead and make a fist. And then open your hand. And we'll release the ulnar. And we see the blood flow return as well there. We would obviously test that bilaterally, but we are not going to do that for this exam. So this patient's cardiovascular and peripheral vascular assessment was unremarkable, and that concludes this exam.